Ladies and gentlemen, I'm very honored to welcome you today to this webinar of the International Society of Gynecological Endocrinology, in short ISGE, as much as I am honored to chair this event. In these challenging times of COVID-19, we are missing the personal exchange of knowledge, ideas, and opinions between colleagues at congresses, workshops, or other meetings. All the more, we have to appreciate the possibilities modern conference technology is giving us to bridge the gaps between us. Using this technology, like we do today, Louis Pasteur's words have never been so true. Science knows no country, because knowledge belongs to humanity and is the light which illuminates the world. Today, we will illuminate the area of phytotherapy. The treatment of a wide variety of diseases using plant-based medicines is today steadily gaining importance. In terms of their pharmaceutical efficacy, safety, and quality, modern researched phytomedicines have to follow allopathic principles and have to find their place in evidence-based medicine. Topic of this interdisciplinary event today is treatment of menopausal symptoms and acute urinary tract infections. What is the role of evidence-based phytotherapy? Our first speaker today is Professor Andrea Genazzani. He is a professor of obstetrics and gynecology of the University of Pisa, president of the International Society of Gynecological Endocrinology, president of the European Society of Gynecology, Secretary General of the International Academy of Human Reproduction, and he is editor-in-chief of Gynecological and Reproductive Endocrinology and Metabolism and the open access journal of the International Society of Gynecological Endocrinology. Professor Genazzani today will talk about black cohosh, which is Cimicifuga racemosa, for menopausal symptoms, which patients are most likely to benefit. Please, Professor, the floor is yours.
Thank you. Thank you, Ariel. It's my pleasure to be here today. And I thank you and thank all the organization for that space that you give me. You know, this is my presentation. And I would like to go to the, 1 second. Okay, and these are my disclosure, and I would like to go on this lecture. Everything starts from what happened in the female brain. In humans, we have to be aware that the intracerebral level of steroids is depending from the origin from peripheral glands, and then ovary, adrenal, and placenta during pregnancy provide a source of steroids, but also that we have inside to the brain a local synthesis. You know that either the central nervous system as well the peripheral nervous system, they are very able in producing steroids inside to the brain. And all these steroids, those coming from peripheral endocrine glands and those locally produced, they go to intracerebral metabolism and production. And one second. What are the mechanisms by which sex steroids they can impact the brain? First of all, one is the organizational. As you know, the brain is sexually dimorphic. This difference between the fundamental female brain, all we are born with a female brain. Then, in men, the brain is transformed and modified to male brain. How this happen? This happen because during pregnancy, the testes in the fetus produces androgen, and this androgen acts on the brain structure, modifying the structure of the brain. In that, and this is also reinforced by the augmentation of androgen at the second, third months of postnatal life. All this make that we have a female brain and a male brain. Then we have the sex steroids. They have sex-specific hormone action to activate the cell of the brain. They can interfere in neurotransmitter function. They can modify receptor subtype. They can induce receptor. They have genomic and membrane effects. They can affect oxidative metabolism and apoptosis, and they have very profound effect at cellular levels, either on neuron as well on glial cells. They can modulate the number of synapses, the local inflammation, and they have very profound neurovascular effects. I was telling you that we have a central nervous system sexual dimorphism. In what is based the sexual dimorphism? That we have different estrogen, progesterone, and androgen receptor expression in the brain areas, different receptor polymorphism, and different steroid metabolism. And this brings to difference also in the structure of the brain, and with different neuronal subpopulation in the various brain areas. But what brings that sexual dimorphism? This brings that we have women and men, a different sexual orientation, a different gender identity, a cognitive dimorphism. We have a specific and dimorphic response to hormone therapy, and also that we have a particular prevalence of neurologic and psychiatric disease. When we look how the sex hormones, they can influence the neurotransmitter activity, I want to focus your attention on that point. What is causing the dopamine imbalance? It brings today tiredness, to loss of concentration and attention, to loss of libido, and to depression. And what is inducing neuroepinephrine imbalance? Loss in motivation, concentration, restriction, and lack of drive. And what serotonin imbalance? We know well: concentration problem, insomnia, cravings, weight gain, depression, anxiety, exhaustion, headaches. Then you can see that some common point, such as the decline in motivation and attention, the fatigue, and sleep disorder and depression, they can all depend from the effect on neurotransmitter activity. And then now, why is important what Cimicifuga racemosa dry extract is doing, for climateric complaint? We will start with some pharmacological data. First of all, you remember in pathophysiology that the reduced level of estrogen and the fluctuation in hormone level, they can lead to the onset of hot flashes, to an increased risk of depression and mood disorders, to osteoporosis, and to changes in body weight, in body fat distribution, and the body weight gain. In the other side, the Cimicifuga racemosa extra DNO 1055 shows serotoninergic activity and reduction of hot flashes, antidepressant effect, osteoprotective effect, and anti-adipogenic effects. By this way, I want to show you. This is just to show how the Cimicifuga racemosa alcoholic extract do not interact with estrogen receptor, either with the alpha receptor or with the beta receptor. That this leads to no undesired estrogenic effects on the endometrium and on the breast. This is something very important for safety. In the other side, you see in these experiments, which they were published in 2003, and on the right side on serotonin in 2016, how the ethanolic extract of Cimicifuga racemosa is binding to the dopamine D2 receptor, and is binding to the serotonin 5-HT1A and 5-HT7 receptor in vitro. This is important. This shows clearly how we are using a substance which is stimulating D2 dopamine receptor and which is stimulating the serotonin receptor too. This brings that what it should be, what it is, the mode of action of Cimicifuga racemosa alcoholic extract. who do not exert estrogenic action on estrogen receptor, but influence the serotoninergic, dopaminergic, we have not shown the data, but also GABAergic and dopaminergic central receptor, and then modulate the neurotransmitter activity. This influence explains the positive effect on psychological well-being and on neurovegetative complaints, such as hot flashes and sweating. I want now to bring you back to the most clinical part, starting with that graph that we published in Nature Reviews of Endocrinology in 2018, together with Professor Simoncini, Patrizia Monteleone, Andrea Giannini, and Dr. Mascagni. You can see what are the symptoms of the menopause in the brain. The vasomotor symptoms, the sleep disruption, depression and anxiety, cognitive changes, and migraine. And in the other side, you can see that in any area where the menopause is active, this happen because they are developing specific symptoms. I want just to mention, for example, the important effect on weight and metabolic changes by the obtained and demonstrated by the weight gain, by the increased visceral adiposity and increased waist circumference, and also the effect on musculoskeletal system who bring to joint pain and sarcopenia and who are strongly linked to the osteoporosis. Then you can see that each symptom, each area which is touched by the menopause and specific symptoms. But if we go to see what are the causes of these symptoms, please look in that figure also that vasomotor symptoms and the sleep disruption, they are depending from the changes in noradrenaline, dopamine, serotonin, neurokinin B, kisspeptin, dynorphin, and cortisol. And in the other side, the mood and cognitive function and neuroendocrine activity changes in menopausal women, they are depending also from neurotransmitter changes, from hormone changes, and in that case also from amyloid beta production, and also by the effect of changes in circulating adrenal steroids, which I remind you, they are also reduced DHEA, DHEAS, while it is increased cortisol, very neurotoxic substance. As you can see, all these data support that all the symptoms have a biological basis. All the symptoms have a biological basis. Then what comes out from the clinical studies with Cimicifuga racemosa? The studies done by climadinon, which is the extract, the name of Bionorica for the alcoholic extract of Cimicifuga racemosa, they have been done on the different part of the symptoms originating after the menopause. The first study is the climadinon against climateric complaints. You can see it's a double-blind, randomized, controlled, multi-center studies where the comparator, they were climadinon, 2 tablets a day, or conjugated estrogen, 2 tablets of 0.3 milligram of estrofeminal, or placebo. The inclusion were female patients with climateric complaint of ages from 40 to 60, with the last menstruation more than 6 months ago, with FSH concentration higher than 25 milliunit per ml, and estradiol concentration lower at radioimmunoassay of 40 picogram per milliliter, and at least 3 hot flashes a day. And the treatment duration was 12 weeks after 2 weeks run on. The outcome were the menopause rating scale and the patient diary to evaluate just the hot flashes and sleep behavior, and also the marker for bone metabolism, the endometrium thickness, the vaginal epithelium, and the hormone concentration. Look in that slide, the significant relief of menopausal symptoms. You can see the symptoms, the menopause-related symptoms subgroups, they were divided. The first is climateric main symptoms, then the somatic symptoms, the second group, and the mental symptoms. In gray is the placebo, in rose is the conjugated estrogen, and in pink is climadinon. As you can see, climadinon have induce a positive reduction, absolutely significantly bigger than the placebo and of the same extent as the conjugated estrogen, either for climateric main symptom, as well for the somatic same symptom, and is more active for the mental symptoms. Very interesting point. In the other side, you can see here related to endometrial thickness. The 12 weeks administration do not modify the thickness of the endometrium with climadinon, while conjugated equinestrogen increases of 1 millimeter. Then this is important because this sustains the non-estrogenic effect of climadinon. When we go to see the data on bone metabolism, certainly, as you know, to evaluate the bone, we have to go in treatment of more than 6 months or even more than 1 year. But at least in the short time of the 12 weeks, you can see here that when we evaluate the bone-specific alkaline phosphatase per bar cross labs, you can see that while we have a reduction in that small time, this is to evaluate the bone turnover index, and you can see that the placebo in gray, we have a small reduction, while either climadinon as well conjugated equinestrogen, they give a significant, they give an increase. Then the rise of index in favor of bone formation is similar for climadinon and conjugated estrogen. Then related to the climateric complaints. This is a double-blind randomized control multi-centered study with a subscore of the menopause-related symptom taken from the patient diary and looking to the daily number of sweating episodes and the sleep disturbances. And you can see here, this is after the treatment with climadinon for 8 and 12 weeks, a significant improvement, you can see in pink, of hot flashes, sweating episodes, cardiac complaints, urinary tract complaints, vaginal dryness, joint and muscle pain was seen, you know. And then this is similar also with conjugated estrogen and significantly different from placebo. Then now, for the sleep disorder, I remind you that the sleep disturbances are strongly dependent from what happened in the brain of the woman. And this is also, even in this short time, you can see that the average number of nightly waking up period was reduced under climadinon. And this shows the important effect. Now, we have another series of studies looking to the safety and efficacy. This is an open labeled prospective multicenter study with climadinon, 2 tablets a day. The female patient with climateric complaint, age 50 to 70, with more than 7 hot flashes per week, intact uterus, endometrial thickness less than 5 millimeter, and non-pathological endometrium. And the duration this time was 52 weeks, then 1 year. There were 375 patients. Then the outcome criteria were the endometrium hyperplasia or carcinoma by biopsy, the endometrial thickness evaluated by ultrasound, and also the breast tissue density, the menopause rating scale 2 using the patient diary as in the other study, and the hormone level, bone markers, and laboratory parameters. As you can see here, this is very important. This is the endometrium classification done on 335 biopsy. You know, as to be expected for hormone replacement therapy that normally up to 2% pathological results. Then the SOI bring also to 3.3% hyperplasia after 5 years. And here you can see prior to the treatment on the left and after week 52 on the right, you can see that we have no pathological results and no pathological increase. And then we have a huge increase of the number of low endometrial thickness. Then we have no pathological endometrium findings after 52 weeks, 1 year of treatment with 2 tablets a day of climadinon. And then concerning to the breast tissue density, this is also something very important. You know, the fear of the women of the hormone replacement therapy is mostly done for the effect on the breast. But with climadinon, you can see that concerning the breast density, This was found normal after 1 year of treatment in 99.28% of the patients, while you know, the brain density after continuous combined hormone replacement therapy, and also is reported here on the right side. You can see that we have 46% of the patients who have an increase in the breast density. You know, breast density did not change after climadinon treatment, while treatment with hormones results in an increased breast tissue density, which we know very well. In the other side, the hot flashes. This is the, you can see here, we have the behavior of hot flashes. They were evaluated over a 4-week period, and you can see here that after 8 weeks, they go down to the maximal level seen of the placebo, which was 50%, and you have a very important reduction, and this is maintained until the end of the treatment. Then climadinon reduced hot flashes significantly by nearly 80%. Then, concerning to the safety study for climadinon, 1 year of therapy, 2 tablets a day, no negative effects on endometrial histology, first point, no increase in endometrial thickness, no increase in breast tissue density, and no clinically relevant changes in clinical chemistry. The bone markers improve in subgroup with high cross-lab concentration, and results confirm the efficacy in the treatment of climateric complaints, an excellent relief of hot flashes during long-term application. Then, ladies and gentlemen, I think it is clear that Cimicifuga racemosa alcoholic extract, as that one that you have in climadinon, can provide results showing its capacity to be absolutely used as first-line therapy for menopausal complaints. I thank you very much for your attention.
Thank you very much, Andrea, for this instructive presentation. There will be time for questions. I'm sure there will be many coming in after our second lecture, and please keep in mind for that, please use the Q&A button at the bottom of your screen. Coming to the next topic, urinary tract infections, mainly cystitis, are among the most frequent infectious diseases if we talk about bacteria. And they affect mainly women, and only until now are mostly treated with antibiotics. On the other hand, antibiotic resistance increases significantly worldwide and has become a threat to global public health. Talking about this challenge, I now would like to introduce Professor Kurt Naber. He started 1992 as an associate professor at the Technical University of Munich. Between 1975 to 2006, he was head of the Department of Urology at a well-known hospital, St. Elisabeth in Straubing in Bavaria, until his retirement 2006. Kurt was president of the Paul-Ehrlich Society of Chemotherapy, was president between 2005 and 2009 of the International Society for Antimicrobial Chemotherapy. Kurt was chairman of the European section for infections in urology and the panel for the EAU guidelines, urological infections. His scientific interest mainly comprises urological infections. His scientific work includes more than 800 articles published in national and international scientific books and periodicals. Professor Naber will talk about the question, do we always need antibiotic therapy to treat uncomplicated cystitis in female patients? Please, Kurt, take over.
Yeah, thank you very much for the opportunity to be part of this webinar. Now this is my slide. Very good.
Thank you.
So, as was said, do we really need always antibiotic for treatment of especially uncomplicated cystitis in female patients? Okay, this is my disclosure. I'm connected to most of the companies who deal with antibiotic therapy of urinary tract infection. Okay, first we have to agree on a definition. Uncomplicated cystitis is defined as acute, sporadic, or recurrent cystitis limited to non-pregnant women. And very important, with no known relevant anatomical functional abnormalities or comorbidities. Okay. If we use this as a definition, then still we have a high number of UTI in women. More than 30% will have some kind of infection, and 20 to 30% of them will have recurrent urinary tract infection. And of course, as you know, intercourse seems to be also a high risk factor. Now, a recurrent UTI have risk factors, as we said. Some are urogenital risk factors: incontinence, urinary obstruction, sphincter detrusor synergy, and urological surgery. This, of course, the urologist should take care and improve as possible. But then we also have general. What does it mean? History of UTI. There's a history of UTI in this women. What does it mean? It means there's a genetic factor. Mother has recurrent UTI, daughter has recurrent UTI, or diabetes, estrogen deficiency. But there are also behavioral risk factors. As I mentioned, sexual intercourse, diaphragma usage, spermicides, or recent antibiotics. Now, let's come to the diagnostics. Of course, you know from the textbook, we need a history. We have to ask about recurrent UTI and complicating factors. Then we have to ask for the typical symptoms, which usually are frequency, urinary frequency, urgency, dysuria. Physical examination, at least we need to see whether there's flank pain, suprapubic pain, and maybe in gynecology, we have to differentiate between all these genital infections. For urinalysis, we usually use a stick. To that, what can we do with a stick? We can measure pyuria, and we can, this is very important. Microscopy, most doctors will not do. It's too difficult. Urine culture, it's recommended, but usually we treat without urine culture. We need urine culture for epidemiology. That is important. Then it comes a question, if you talk to a microbiologist, there's a big question. What is a significant bacteriuria? And then they say, there's no bacteriuria. Does it mean the urine is sterile? No, that's not true. No urine is sterile. And usually they tell you 10 to 5 is a significant bacteriuria. But 10 to 5 has a very low sensitivity. Only 50% of the patients you will get. No, they have to dilute, and they don't like to work on that. And therefore, usually they have said 10 to 3. But even now, data show that 10 to 1 can be very, very important. And even then, 20% of symptomatic female will have culture negative. And if you do PCR, of course, then still you can find E. coli and Staph saprophyticus in the urine. So that means there is no significant bacteriuria anymore. That means we need the clinical evaluation of cystitis much more. But clinical evaluation is subjective by principle. And in order to reduce the principle of subjectivity, we have developed this acute cystitis symptom score questionnaire. Here we ask for the typical symptoms: frequency, urgency, dysuria, pain during urination, incomplete bladder emptying, suprapubic pain, or visible blood. This is cystitis. But we also ask for differential diagnosis: loin pain, flank pain for pyelonephritis, vaginal discharge, abnormal vaginal discharge. Is there any genital infection? And high body temperature, of course, whether there is pyelonephritis. Then we ask about quality of life, and we ask about additional questions is there just at the moment, menstruation or premenstrual syndrome, menopause syndromes, or pregnancy or diabetes. If we ask this, then we can find that with this questionnaire, at a score of typical symptoms of 6 and higher, has a sensitivity of about 80% and specificity of about 80% versus controls. And this is, of course, a clinical diagnosis with high sensitivity, high specificity, without any urine culture. However, if we can have a urine sample, at least we should look for pyuria. Pyuria and this questionnaire would give you a very high sensitivity and specificity. Now, as Dr. Seidenwerg has said already, antimicrobial resistance is increasing worldwide. If you look at the worldwide map, you can find, especially in China, India, we have third-generation cephalosporin resistance, that is ESBL, extended from beta-lactamases. But also in other countries, here, Eastern European countries, you have here Poland and so on. And in Europe, also there are some countries with high resistance, Greece, for example. Then if we go to fluoroquinolone resistance, again, China, India are the champions. But here again, we have high resistance rate in Poland and in some Balkan states. Carbapenem resistance, India, even very high, not so much in Europe and North America. But now, if we go to the guidelines, then as also Dr. Seidenwerg said, usually antimicrobials are recommended. For example, the EAU, European Association Urology Guidelines, recommend old antibiotics, fosfomycin, nitrofurantoin, or even nitroxolin in the German guidelines, pifmetzelina. We should not use cephalosporins, third generation. We should not use fluoroquinolones. And in many countries, we even cannot use trimethoprim because the resistance is higher than 20%. And also, why should we not use cephalosporins, fluoroquinolones? Because of resistance. That is one part. The other part is that we select resistance. We have collateral damage. We select ESBL. We even select Clostridium difficile infections. This is not so much the case with the old antibiotics, fosfomycin, nitrofurantoin, pifmetzelina. Therefore, antibiotic consumption, that is a biological law. By biological law, antibiotic consumption will select antibiotic resistance. Of course, we cannot change this in principle. Then some people thought, if uncomplicated cystitis is, let's say, a benign infection, maybe we should only treat the symptoms. And that was an interesting study. They said ibuprofen versus fosfomycin can be used just symptomatic treatment. Here you can see in the summary that patients were treated and randomly either fosfomycin gram single dose or ibuprofen 400 milligram. It's a high dose, 3 times daily, also for 3 days. And here you can see if we have a scoring system, it starts with a high score. And then the fosfomycin is better than ibuprofen, but still with ibuprofen, after 7 days, we can reach very good results. Then the question was, if we treat with ibuprofen and fosfomycin, high dose ibuprofen, are there side effects? Yeah, there are side effects, of course, with the antibiotic. Usually we have gastrointestinal symptoms, diarrhea or nausea. And ibuprofen, one patient had gastrointestinal hemorrhage, because 400 milligram is fairly high, 3 times daily is fairly high dose. So that's not the best. But then the question came, okay, if you use a symptomatic therapy, usually the DA and EMA will ask you, okay, if you use symptomatic therapy, yeah, that's good as long as you use the treatment. But then, of course, you do not eliminate the bacteriuria, therefore you will get relapse and recurrences. Is this true? For example, you can find, if you use ibuprofen, there were 5 pyelonephritis, it was fomecin 1. Okay, there's a little more, but it's not significant. Then also it shows who gets recurrent UTI. Who gets recurrent UTI? If they use fosfomycin versus ibuprofen, is there a difference? No. Antibiotic treatment, because some want to have antibiotic if they have used ibuprofen. Antibiotic, non-antibiotic treatment, no. Does it depend on the urine culture? High culture, low culture, negative culture at the end of treatment? No. The only factor which is significant is if there is a history of previous UTI, they will get recurrent UTI. That means the recurrent UTI is inherent because of risk factors. The risk factors can be genetic, can be whatever we have mentioned. It has nothing to do with the treatment of the acute episode. I think this is a very important, and they have followed this for 6 months, half a year. Now we can say non-antibiotic treatment had no negative impact on the recurrent UTI rate. It has a little bit higher pyelonephritis rate, but otherwise no negative impact. Now we talk about phytotherapy today, and I would like to discuss a little bit more the phytotherapeutic drug, which is a composition of centauri, lovage, and rosemary. The name CLR, and I do not show you all the preclinical results, but it can be shown in preclinical studies that it has a diuretic effect, a spasmolytic effect, an anti-inflammatory effect, very important for us now, antioxidative and nephroprotective effect. This can be shown in preclinical studies. And then a study was done, a prospective randomized double-blind phase 3 study was done, where this herbal therapy, BNO 1045 versus fosfomycin in acute uncomplicated cystitis in women. And I can show you here that after randomization, this canifrone, that is the name, and fosfomycin placebo in 325 patients for 1 week. 1 week. And fosfomycin, 1 single dose, and canifrone placebo. And then the acute cystitis symptom score was used in order to have specifically the symptomatic effect of the treatment. Now here, see how many patients were enrolled, and finally in the full assessment we had more than 300 patients in each group, and even in the per protocol there are about 300 patients in each group, so it's a very good study. Now here you can see the one most important result. We have discussed what would be the best result if we cannot use bacteriuria, if we probably don't want to use symptomatic therapy with the RCSS. What could we use? And therefore we said, very simple, if a patient would like to have an additional antibiotic, then this would be a failure. And that is very simple, because the patient does not know, does he have fosfomycin or canifrone? And the patient or the doctor came to the conclusion, it does not work well enough, therefore I would like to have an additional antibiotic. And here we measured how many patients wanted to have additional antibiotic within 30 days, 38 days. And here you can see about 10% of the patients receiving fosfomycin asked for an additional antibiotic. So we say the overall success rate of fosfomycin is 90%. Makes sense. And now you go to canifrone. Now you can see 16.5% asked to get an additional antibiotic. And you can see the difference is about 6-7%. 6-7%. And if we use a non-inferiority margin of 50%, then we can say both treatments are non-inferior. And this is the result that is a main result I wanted to show. Here I show you, if you use the RCSS, the acute cystitis symptom score, then both groups start with a high score. The score is 10. This is standard deviation. And after 4 days, 5 days, they are almost the same. Here you see the standard deviation, almost the same. And 8 days, they are absolutely the same. And after 4 weeks, again, they are the same. Whether you have fosfomycin or you have canifrone as symptomatic therapy. Then we measured the other thing. We measured what is the quality of life. What is the difference in quality of life? And we measured here. This means the blue one are excellent. Dark blue is excellent. Red is, I feel very bad. At the beginning, you have only 20% which are fairly good. That is light blue. And some feel very bad. And many of them feel at least significant discomfort. Then you can see at day 4, after 4 days, already the light blue gets up. After 8 days, black means we have no data. That you can see it's almost the same. And after 30 days, there's slightly better in fosfomycin, but this is all within the non-inferiority margin. I think we can show here that this phytotherapeutic drug, if you use this phytotherapeutic drug for acute uncomplicated cystitis, 15-16% of the patients will not need any antibiotic. And you can save 85% of antibiotics. And in the fosfomycin group, 110 have used antibiotics. And now you can see the discrepancy. And so we can save a lot of antibiotics. We still give the patient symptomatic therapy and tell her, of course, we talk about women, and tell her, if the effect is not good enough, of course you can take an antibiotic. You can take an antibiotic, but this will be in 10-15% of the cases, and not in 110% of the cases, like in fosfomycin, 100%, and in additional 10%. And I think if we save antibiotics, we will contribute to reduction of increase of resistance, and we can save the antibiotics. Now, adverse events. I told you that gastrointestinal disorders, we have about the same numbers, but they are different. We have more gastrointestinal diarrhea, and here we may have some abdominal pain and so on. And the only difference what we have to think about is that in caniferone we have 5 cases of pyelonephritis. In fosfomycin, still we have 1. If we look to other studies, it's about the same. Symptomatic therapy with ibuprofen 5, with fosfomycin 1, another symptomatic 6 and 0. Why is this the case? We have observed that this pyelonephritis all happens within the first 3 days. So that means this is a pyelonephritis which just has started with cystitis. If we have to tell the patients, sometimes the cystitis, the pyelonephritis starts with cystitis, and if you have fever the next day or the day after, or flank pain, of course you can take an antibiotic, you should take an antibiotic. So if we explain our patient what we are doing, I think it is a safe therapy as well. Now, the summary, there was non-inferiority between caniferone versus fosfomycin. And if we use additional intake of antibiotics, we have the reduction of the symptom score is about the same. And there were no marked difference in adverse events. Of course, we have to consider pyelonephritis as a starting pyelonephritis, each cystitis, but the rate is 0.5% or 2%. So it's a very low rate we have to consider. Thank you very much for your attention. Thank you.
Thank you, Kurt, for this very interesting lecture. And now, ladies and gentlemen, I got a load of questions coming in here, which I have to a little bit to put on different pages. But I will start asking Andrea. There are many questions regarding unwanted side effects using black cohosh. For example, and the main questions are about what is the effect or unwanted effect on liver, because there have been reports, as I remember many years ago, about liver toxicity. Can you,
yes,
Andrea, can you talk about that?
Yes, I think, this is, the studies on liver toxicity, they were published some years ago, and but they were based on different extract. The problem is that the plant can be the same, but the extraction is done with different substances. These alcoholic extract coming as we are using now with Cimicifuga racemosa don't have any in all studies, any effect on liver function, while other kind of extract they can do. This, I think, is dependent from the quality of the extract and from the substances also were present in the extract. I think that with climadinon, all the data were ensuring for safety and for efficacy too.
Okay, thank you, Andrea. Kurt, here comes a question regarding caniferone, the use of antibiotic in treating urinary tract infections. I know that in most countries, if not in every, they are always looking to guidelines. So do you think that this will change the guidelines, like from the European Association regarding the treatment?
Yeah, it should, of course. But this was the first prospective randomized study, and therefore it will change. For example, in the German guidelines, this is already reflected, because if we have good studies, then the studies will be included and will have some evidence also for the guidelines. But so far, we had no good studies before. Now we have a good study.
Okay. Andrea, here there are questions coming in regarding the difference of hormone replacement therapy and use of phytotherapy of climadinon regarding the risk, cardiovascular risk and bone health.
Yes, okay. there are no studies until now in long duration for this kind of risk. That what we can see now is that both climadinon and hormone therapy are efficient for the bone mass preservation. And the studies done until now, they have not shown any cardiovascular deterioration under climadinon therapy. Certainly, more studies will be needed for the long-term therapy. What I mean as long-term therapy means that therapy is over 5 years of time. No studies were done comparing this, the phytotherapy, any phytotherapy and hormone therapy for more than 1 year. And then we have only episodic data for that one.
Okay, thank you very much. Kurt, changing to you again, there are some questions coming in regarding the diagnosis of urinary tract infections. Do you see a concept of defining urinary tract infection by bacterial numbers in the urine and to use a cut-off level? Or should the symptom-oriented therapy be the main goal of a successful treatment?
Yeah, this is a big problem because the microbiologists and unfortunately also EMA, FDA, they all define that you have symptoms, of course, symptoms, you have pyuria, and there should be a so-called significant bacteriuria. And then they define significant bacteriuria 10 to 5. But we have studies enough showing that this is insensitive. Yes, of course, acute cystitis is a bacterial infection, no question about. But then you have to go down to 10 to 2 or 10 to 1, or even PCR. Then you will find the bacteria. But the microbiologists don't want to do this. And this is a problem. Then they tell you the urine is sterile. There's no sterile urine anymore. We know from nowadays there is always a microbiome in the urine. And therefore, at least for the routine diagnostics, we think that clinical diagnostics and probably pyuria are good enough for the diagnosis of acute cystitis.
Okay, thank you very much. Andrea,
Yes.
For you again, there's a question, climadinon used after chemotherapy-induced menopause, and regarding the breast cancer when with hormone receptors positive when they are treated with tamoxifen.
Yes, you know, one point is the climadinon effect on the estrogen receptor. As you have seen, all the data don't show that climadinon can interact with estrogen and cannot bind to the estrogen receptor. Then the problem when estrogen receptors are important in the development of the disease or in the maintenance of the disease as the breast cancer, this is not an area with climadinon. This is not an area with climadinon. I think climadinon can be used also in patients with breast cancer because it don't interact with the estrogen receptor while it interacts on the brain with those areas where develop the symptoms such as flashes.
Okay, ping pong to you, Kurt, regarding the treatment of uncomplicated cystitis in women. I mean, when is the decision? Do you always use antibiotic therapy, or like you have shown now, is phytotherapy with carnitine the right thing? And if you have to use antibiotics, which one would you use?
Okay, now the recommendation, for example, could be the following. This has started many years ago. They said, if this is an acute uncomplicated cystitis is a benign infection, we can tell the women that if you don't need any antibiotic and you take symptomatic therapy, you should not use. But in any case, if it does not work enough, then you can take an antibiotic. And this is our recommendation. You should start, for example, with this phytotherapy by symptomatic therapy, but here you can take an antibiotic if you like. Then what kind of antibiotic in case 10%, 15%, only the old antibiotics, fosfomycin, nitrofurantoin, nitroxolin. Don't use cephalosporins, don't use fluoroquinolones, and in most countries don't use any more trimethoprim because the resistance is so high. So antibiotics are second line for 10-15%.
Okay, thanks. Andrea,
Yes.
would you recommend, or the question is, why is Cimicifuga racemosa clamadienol extract considered as a first-line strategy? I mean, compared to hormone replacement therapy. I mean, I think we have to give a roundup there again.
Yes. You know, we have the first observation that we have to do is that women, independently that the majority of them, they develop symptoms at menopause, and some of them very severe symptoms who also last for many years. The majority of them, they don't want to use hormones. They are afraid by the use of hormones. This is the reality. If you see in the majority of the countries, only 5-10% of women with symptoms, they take hormone therapy because they are afraid by the hormone use. Then this is the first point that we have. In the other side, phytotherapy with climadinon, alcoholic extract of Cimicifuga racemosa have shown efficacy and safety. Then why not to start also for all of those who don't want? But also, why not to start for the symptomatics to check if they are a good response with the climadinon, and if they have a good response with to follow with climadinon. How long to follow? We have studies published until 1 year, but we have also studies going on which of women who are taking phytotherapy for more than 1 year, 2 years, 3 years, 4 years, they are following. Certainly, very long studies I have published are still lacking. This is something that we have to do. But I would like to suggest for women, for all those who don't want to take hormones, to start with phytotherapy. For women who are in doubt, to start with phytotherapy and then to check. But for women who want to take hormones because that they believe that they have to take hormones for many other aspects of hormonal effects, they have to do this. Safety.
Right. Okay. Thanks. Kurt, question: how many days will you wait, or will you wait to start with antibiotics in patients that use canifrone and they don't have a significant better symptoms that they complain about?
Yeah, I would say in the third day, if the patient has no change, relief until the third day, then probably she could take an antibiotic. But if she can see there is already a good effect, okay, then she could wait, because the complete effect takes some time. The same is true with antibiotics. It takes some time. But the third day, I would make that decision.
Okay, Andrea.
Yes.
You again. Which is the doses with climadienol as an alternative for hormone replacement therapy? 20 or 40 milligrams in a longer term treatment?
Yes, I think we have to titrate. We have to start with 40 milligrams. We have to start with 40 milligrams. We have to follow the patients. After, also in the strongness of the symptom of the climateric symptoms, after time they are declining. Then I think after 1 year you can go down to 20 milligrams. Maybe you can follow with 20 milligrams.
Right. Okay, understood. Good question from far away. Any studies done effect of canifrone on female reproductive health?
Canifrone on what? Reproductive health?
Yes. Is there any significance in
we have a gynecologist. He could. We have a gynecologist in our team. He could answer this.
But
I don't know.
as much as I heard and seen the study, I think all the safety studies have been done. So I think there's no danger. I think this is the positive thing. I mean, if you prove the efficacy and safety of phytomedicine and it's evidence-based, of course, you have to answer the question for safety, and then you have the answer. So I think we can be very, very sure that this is working very well.
If I can add something, I wanted to tell you that in comparison to antibiotics, when we cannot take antibiotics, always reproductive events are always affected in a more favorable way by non-use of antibiotics.
Okay, I can also add something. We did an overview of all the adverse events, and I could not find any notes on adverse events on this. Okay. Fine.
Andrea, question here. I mean, if you look for hormone replacement therapy, certain strategies have to be used to maximize the benefits, and you have to see the lowest effective dose, the lowest duration as possible. I mean, do you think that many people are fulfilling this correct use, or how do you see HRT in general?
Okay, speaking about HRT in general, I don't believe that the lowest dose for the lowest time. This is absolutely not true. The right dose, the right way of administration, and all the time needed for the effects on the woman, and the effects who are not only the symptoms, such as the climateric symptoms, but also quality of life, and also relational aspects of the life. As you know, menopause happened at 50. Now in our years, at 50 here, a woman is still a very young woman, full of life, and also her marital life have a very strong importance. And then for these reasons, I believe that the women, they have to decide by themselves. Absolutely, no study have shown and have been published now that you are obliged to stop after 5 years. All women that were after 20 years, they're still under therapy, they have all a series of positive results. And this is the same also for phytotherapy. Phytotherapy have a series of effects on the receptor system that we have mentioned, that they are maintained and also going on with the time. It's not true that you have to stop. If you feel well with this treatment, you can go.
Okay, Kurt, talking about fosfomycin, other antibiotic, and canifone having a significant effect on the urine pH.
The urine pH? No, they do not have. There are some substances which have on a urine pH. The urine usually is acid, as you know, but it can go up to alkaline as well. And for example, if there's an infection with Proteus mirabilis, then you have an alkaline urine. So it depends on the pathogen, and sometimes what you eat. But otherwise, there's no specific effect of canifone on the urine pH. No, it's not.
Okay. I think we are coming to the end, but still, Andrea,
yes.
Who would you suggest would benefit more from HRT and who from Cimicifuga products or from climadinon?
Okay, I think the patients who have more brain originating symptoms without somatic symptoms, they can probably be more favorable effect by Cimicifuga extract. I would like also to add something, looking to the general effect. We have an aspect that we have not to forget, is the low genital tract. And in that way, we have also add to the Cimicifuga extract a local estrogen or a local treatment at lower level. You know, we are now speaking about local estrogen, local estriol, local DHEA, the hydroepiandrosterone, which are all treatment who can be done for their specific effect on lower genital tract, mainly in longer time use, because menopause is deteriorating the female life even more going on. But these do not touch the central Cimicifuga effect.
Okay, Andrea, now second question for you. Whom should we recommend BNO 1055, which is climadinon, with symptoms, a woman with symptoms, or prophylactic at ages 50 plus or later?
I think in subject with symptoms, because the subjects with symptoms, they clearly show how the brain is sensitive to that novel biologic situation. The symptomatic subject is that subject who will follow. The compliance in a symptomatic subject is absolutely better maintained than the compliance in a subject who have no symptoms and only want to do for prophylactic reason. But she have also to be aware, she can have symptoms also before the menopause. Some women, they develop hot flashes during the menstruation time. Some women develop hot flashes also during the luteal phase time, in the latest year of, not of fertility, of menstrual life. Then these women, when they start with symptoms also even having still menstruation, in that one, I suggest the climadinon use in premenopausal time.
Okay, understood. Kurt, there's a very interesting question came up about the effect, the benefits of using phytomedicine like canifrone, especially here in this webinar. Beside the fight against the antibiotic resistance, I mean, there are other benefits of it, and there was the word microbiome was mentioned. Can you elaborate on this a little bit?
Yeah, I can. Okay, they are not done so far studies on human. However, one study has been done on mice, and they have compared placebo or water, placebo, nitrofurantoin, fosfomycin, and canifrone. And then you can see that even nitrofurantoin, fosfomycin, all will have effect on the microbiome. That means it changes the microbiome. And canifrone was very close to placebo or just fluid. So the effect on the microbiome is the lowest with this phytodrug, for example, because, yeah, and this is the principle. We treat the host and we do not treat bacteria, as you say. We treat the symptoms of the host and not bacteria. And for just one sentence, you know the asymptomatic bacteriuria. That means we have so many bacteria in our body and also in our bladder that we are friendly to our bacteria. Then they are friendly to us. It is bacteria are like human. If you are friendly, they are friendly. Collaborate. And if you look at from this side, then of course, don't touch the microbiome.
Okay, so we know we are friendly with everyone. Not every virus is friendly to us anyway. So, okay, ladies and gentlemen, I know that there are many questions, so I'm sorry that I cannot really ask each and every question. The most important ones I will choose, and I will ask our great presenters here maybe to answer it and send it to you. So in all the different countries I've seen here, I think we are connected with even not many countries, but even 2 or 3 continents. So I would like to thank you now at the end for participation in this webinar sponsored by Bionorica. As we have heard, I think we can and have seen that phytomedicine has become an important part of allopathic medicine. If it shows evidence, I think that's important for us physicians, proving efficacy and safety, fulfilling these requirements. And as I know Bionorica's philosophy and procedures prove, research plant-based medicines can be the preferred alternative to chemical and synthetically produced medicines. So many thanks, of course, to our dignified speakers, Professor Genazzani, Professor Naber, Andrea and Kurt, as well, of course, to the International Society of Gynecological Endocrinology, which allowed us to be a part of this event. So in the end, I would like to, in this time especially, wish you and all your families all the best. Stay healthy. Looking forward to meet you soon again, hopefully in person. So goodbye, auf Wiedersehen, do svidania, adio.
Goodbye.
Arrivederci,
Arrivederci.
Arrivederci, of course, arrivederci.
Hi, Harold. And thank you for inviting us to participate.
Yeah, that's
It
true.
was an honor, and we'll do the next time soon again. So thanks for everyone. Stay healthy, and it's great to have you, but I would like to meet you next time all in one room without masks, and so let's work on that. So bye-bye.
Okay. Goodbye.
Bye.